I'm delighted to introduce the members of the clinical team from Dana Farber and Brigham and Women's Cancer Center, who will be our speakers today. Radiation oncology providers have steadily been adopting MRI for image guidance and gynecological and prostate brachytherapy for increased clinical benefit, but also recognize that differences in patients' position between CT and image registration could introduce potential radiation delivery errors. MR conditional patient positioning equipment that enables consistent lithotomy positioning from procedure to imaging may help to reduce these risks. We will begin today's session with Dr. Michael Dyer, gynecological brachytherapy radiation oncologist, who will provide a short overview of the department's brachytherapy program. Dr. Alia Kaza is the chief physicist investigator, and she will review the technical results of the study. We will conclude with Alex Marques, chief radiation therapist, who will provide a clinical perspective on the use of the stirrups and future outlook. Thank you so much for your attention, and with that, I'll hand it over to Dr. Dyer.
Thank you, Christy. Before Dr. Kaza and Alex speak more specifically about the MR conditional stirrups, I'll just spend a few minutes on some general background on MRI-guided GYN brachytherapy and its use in our GYN radiation oncology program at Dana Farber Cancer Institute and Brigham and Women's Hospital. MRI has the potential to increase the therapeutic ratio in GYN brachytherapy compared to less advanced techniques such as point A based planning or CT only guided brachytherapy. This is for a variety of reasons, including better delineation of gross tumor volume, cervix, soft tissue, and organs at risk, and the interface between these structures. Initially there was concern when groups started moving to image-guided brachytherapy and adaptive brachytherapy and moving away from point A-based planning for cervical cancer, that this could result in poor coverage of gross or microscopic disease. But fortunately, evidence suggests that this more targeted, individualized treatment does not result in compromised oncologic outcomes. Some of the best data that we have comes from the EMBRACE studies. EMBRACE-1 was a cohort study of MRI-based image-guided adaptive brachytherapy in locally advanced cervical cancer. It was prospective and it was built upon the data from a prior retrospective EMBRACE study. Prospectively, over 1,300 patients were enrolled from 24 centers in Europe, Asia, and North America. And instead of, in this study, focusing on getting 75 to 85 gray to point A, that same point for all patients, EMBRACE methodology focuses on individualized 3D target delineation and planning aims and constraints specific to these three-dimensional structures as defined on MRI. EMBRACE-1 had very impressive outcomes. There was an unprecedented overall local control of 92%, despite including a high number of advanced stage patients. There was a limited incidence of grade 3 to 4 morbidity per individual organ, but it was significant overall, and the current EMBRACE-2 protocol is working to further decrease that. Another takeaway from the EMBRACE data is that hybrid intracavitary and interstitial brachytherapy may result in less morbidity and better target coverage compared to intracavitary tandem and ovoid or tandem and ring brachytherapy alone without any interstitial needles. So MRI-guided brachy is now the gold standard in GYN radiation oncology. We have been using MRI-guided brachy at our center for a number of years. Initially, this was outside of our department in what's called the Amigo suite at Brigham and Women's Hospital. And then in recent years, we have built a MRI simulator, the MRI-guided Advanced Procedure and Simulations, or MAPS suite. And we now do the vast majority of our GYN brachytherapy procedures involving MAPS as our MRI guidance. And this has allowed us greater access to MRI-guided brachytherapy as opposed to when we were using Amigo suite and relying on resources outside of our department. To give you a sense of the scope and size of our program, we treat approximately 60 patients, individual patients per year with intracavitary, like tandem and ovoid or tandem and ring. This is not including cylinder patients. Intracavitary hybrid, intercavitary interstitial, and interstitial HDR brachytherapy. We've had an increase in complexity of cases over time, as you can see on the graph here, with blue representing the simple pure intracavitary TNO or TNR implants, which have decreased over time, and the complex GYN cases, interstitial or hybrid intercavitary interstitial cases, have increased over time, and that's for a number of reasons, including the data support using hybrid applicators for many patients, including patients with cervical cancer who have parametrial involvement or larger tumors, and because we are a referral center that tends to get very advanced cases from all over New England. In 2021, last year, about 75% of our patients were treated with MRI guidance using our MAPS suite. Finally, I'll show a few images from recent MR-guided brachy cases at our institution. This is a patient with very locally advanced clinical T3B cervical cancer who had a poor response to initial chemotherapy and external beam radiation therapy. We did a tandem and template interstitial implant. And you can see here how well we can delineate on this MRI the target from the surrounding structures, including uninvolved soft tissue and parametria, and rectum, bladder, and sigmoid colon. This is the corresponding CT scan for the same patient, where it is much more difficult to delineate target from soft tissue and OARs. This is the treatment plan for that same patient. This is another patient with a periurethral distal vaginal drop metastasis from endometrial cancer. And again, you can see how MRI really aids in target delineation. And then finally, this is another patient with an endometrial cancer, vaginal cuff recurrence, as well as a drop met in the distal vagina. And we're able to achieve very nice metrics with a template-based interstitial implant, where we can very clearly see tumor, surrounding soft tissue, and OARs on our MRI.
Thank you very much, Dr. Dyer. And I will go on with presenting the technical evaluation of the hoverboard and stirrups. My name is Evangelia Kaza, ALIA for short. So the goal of these tests was to evaluate the prototype Dyer HDR hoverboard with a MRTEC 350 stirrups in a 3 Tesla Siemens Vida, using as criteria projectile risks or possible hitting risks, the extent of metal artifacts on the images, and the overall suitability of images for treatment planning. As a subjects for the test, we used MRI phantoms and 2 female volunteers. Our initial tests with a handheld magnet showed that there were no projectile risks at 3 Tesla, and it was possible to use the hoverboard and stirrups in such a scanner. For the hitting and artifact tests, we have used 3 phantom setups. In test A, we used a large sphere at the edge of the mat on the hoverboard in a position that was simulating the pelvis. In tests B and C, we used phantoms very close to the stirrups so that we can quantify the extent of possible metal artifacts. In each of these tests, we were measuring also the temperature at points shown by the red numbers in the photos using a non-contact infrared thermometer. The results of our temperature measurements are shown in this graph for each location, and the material that was used in each location is shown at the top of the graph. The blue line shows the temperature measured at baseline, meaning before scanning, and the red, green, and yellow bars show the temperature after each test. The maximum temperature difference that we have measured was 3.3 degrees Celsius for location 2, which was the vinyl-covered aluminium stirrup joint. The overall maximum temperature that we have measured was for the aluminium rail mount, and it was 22 degrees Celsius, again just 3 degrees above the baseline, above the exam room temperature. The least warming was measured for the non-metallic parts, as expected, and those farther from isocenter. From these results, also from the fact that no heating was felt by placing a hand at these locations after the scans, we have deduced that there are no heating risks by using these hoverboard and stirrups in a 3 Tesla scanner. The results of the artifact tests are shown here. The shortest artifact-free length measured for test A was 18 centimeters on vibe and beat sequences with trophy contrast. And for test B, it was 17 centimeters for vibe sequences. The largest artifact extent from the stirrup blades was 18 centimeters for the vibe sequence on test B and 23 centimeters for a still sequence on test C. For the volunteer tests, we scanned 2 healthy female volunteers in a standard position and in the stirrups position. And we have used sequences from our clinical and research protocols, including T1, T2, and diffusion-weighted sequences, with a total acquisition time of about 45 minutes. Our evaluation of the artifacts on the images has shown that there were signal cancellation artifacts by the metallic components, as we have also observed on the phantoms, but these were obvious only in posterior hip areas, as shown by the yellow arrows here, and they did not affect the areas of interest for gynecological or prostate brachytherapy. And the artifacts were overall more prominent on T2-weighted images. Comparing the overall image quality in the standard position versus the Dyer position, we have seen that pelvic organ visibility was similar, and it was considered adequate for treatment planning and contour generation, although there was a signal drop in posterior areas when using the Dyer boards, as you can see here on these images. To evaluate whether this signal drop was due to increased distance from the posterior coil or due to materials used in the hoverboard, we have performed phantom scans by placing the phantom either on a metal board or using a hoverboard mat in between, or placing the phantom in a position that we had an air gap underneath it. Then we have drawn regions of interest on the images. Examples are shown here. This is the cross-section of the phantom, and these colored boxes are the regions of interest from which we have extracted signal for the yellow ones and noise for the other two in the background to calculate signal to noise ratio. The results of this test for the sequences that we used as T2 haste, T2 weighted space, and T1 weighted vibe are shown in these graphs here as a percent of the maximum SNR. For the T2 weighted haste, we see that all results look similar. For the space, results are rather contradictory between metal and air for different slice locations, and this is also the case for the vibe. We can see that SNR for the mat is higher in this lastly acquired sequence, but this may be due to the fact that the phantom may be sagging with time. So overall, we did not see a clear SNR dependence of the materials of the hoverboard, and it is most probable, therefore, that this posterior SNR decrease that we have also observed on the it is most probable that the posterior SNR decrease observed on the volunteer scans was due to the increased distance from the posterior receiving coil. To conclude, the evaluated hoverboard and stirrups presented no MR safety risks at 3 Tesla. On phantom images, metal artifacts were observed close to the stirrup joints, but on the volunteer images, the artifacts were affecting only hip areas, and brachytherapy areas of interest in the pelvis were not affected. Overall, image quality was considered suitable for the treatment planning, and as the device presented no risks, it was considered suitable for clinical use in MR-guided brachytherapy.
Thank you, Alia. My name is Alex Marques, and I'll be presenting on the clinical testing and the future goals of the stirrups with our Dyer system. As Alia had mentioned, our first tests were around MR quality, MR imaging, and MR safety. And then our next test that we wanted to do was actually test how these stirrups compare to our current stirrup systems in the OR, and if they have the same capabilities. As you can see from the image here, this is actually a dedicated suite in our rad-onc department. Pictured, but not pictured, but in the room here is a CT scanner. So this is a custom made suite where we can actually perform the implants, both GYN, prostate, HDR, LDR implants on the table here with our Dyer system, and then scan the patient. We're very familiar with Dyer products. We've been using them for many years. And when we first built our MRI simulator, we wanted a commercially available MR conditional stirrup that could use with the Dyer system, which wasn't available at the time. And we were very excited when Dyer came out with this system, and very excited to test it. So initially, how we tested the system was we used it on 4 patients that were undergoing prostate brachytherapy in the room pictured here. Our goals were to make sure they were comparable to our current system. We use our current system, our current stirrup, as kind of the gold standard. Those are non-MR conditional stirrups. And all of these implants were performed in the rad-onc suite. And the goal was to make sure that these were usable and clinically acceptable for the OR portion before we moved forward with the use. Pictured here was the current system that we had been using with our Dyer system, the yellowfin stirrups. And then in the far picture there are the MR conditional offerings from Dyer. So what we found was the MR stirrups yielded very similar results in terms of range of motion, very comparable. Patient was able to get into lithotomy position in a very similar way as they were with the current system we were using. So what we had concluded from that was we could use these stirrups in the same way we're using our current system. Therefore, they were safe and comparable to use for our implants, whether that be in the MR environment or not in the MR environment. It is good to note that the stirrups are different functionally, how you turn the stirrups, how you move the stirrups, the range of motion, how the shocks work. So the clamps are different from other offerings. So it is important to note that the training should be performed either on a volunteer or with the system prior to using the system, just to get the team familiar with how the functionality works in order to use them efficiently when they're actually using it on a patient. That being said, we were excited that we were able to use them in the same way that we were currently using our stirrups, meaning we could go forward with our plans to further expand our MR program and our MR GYN, particularly interstitial cases. So the picture you see here is this is actually a volunteer that's on our MRI table. So one of the bigger things why we wanted an MR system that would work with the Dyer is because the table that you're seeing here in the picture comes from a Siemens 3T Vita, and it's undockable. So the table can actually disconnect from the MRI. So with that being said, when we built this room in radiation oncology, this MRI room, we built the suite itself to also be a procedural room. So we have physiological monitors, we have a ventilator and anesthesia machine. So we built this with the intent to perform implants inside the MR room. So given that, we would be able to perform the implant on the MRI table. We wouldn't have to transfer the patient from different tables, and able to scan the patient in the same exact position right after the implant in the MR. Some of the the barriers that come up initially is all of our implants are done via ultrasound, and currently there isn't a great ultrasound MR conditional ultrasound alternative that can be used in the MR room. So what we do to date is we will perform the implant in our HDR suite, which is the previous image that was shown with the CT scanner via ultrasound. And once we are happy with the implant, we actually bring the patient through our department on this MRI table that you see here. We transfer the patient from the CT table or the procedural table, as imaged earlier, onto this table, and we bring them through our department under anesthesia and scan them, as Dr. Dyer had mentioned, for our planning scans. What these stirrups and this system gives us the capability of doing is, knowing that we can't have an ultrasound in our MRI room, we can further expand trying to use our MRI for real-time guidance. So instead of using the ultrasound for the initial implant, we can further research how we can use an MRI, a live MRI, to guide the needles. So that's something that this allows us to do. As well, what it also allows us to do is not transfer the patient in between, say, an OR, a CT, and an MRI, but to keep them in that same position throughout the MRI. Also, something that we've tested in the past, as mentioned by Dr. Dyer earlier, we have a suite in the hospital that's an OR, an MRI, and a CT all in the same area, where a patient can be transferred from one area to the next for imaging and planning. The issues that we ran into there is we didn't have a MR. We would do the OR or the implant in the OR with a Dyer system, but that Dyer system wasn't MR conditional. So when we had to go to the, let me go back a step. The stirrups were not MR conditional. The actual sled itself was. But when we went to transfer the patient into the MRI, we weren't able to keep the same stirrups on. So if there needed to be adjustments that were done via the MRI, due to MRI images before the implant was complete, we weren't able to do that with the same system that we used in the OR. With this system, that allows that. And also for us, what we're excited about also is not only the real-time needle guidance from the MR, but also researching different MR-only planning alternatives that can be used. Currently, we still do need to acquire a CT on all of these cases, even though the contouring is done on the MRI, given that we don't have a great alternative yet in order to localize and digitize the catheters for these GYN interstitial cases. So we always have to do a CT with markers placed, with strands placed in the catheters in order to localize them for planning. This system allows us to further expand our research on our MR-only planning, given that we could do the implant and the imaging and the adjustments in the MRI. That being said, that's where we're going to conclude there, and I'd like to thank Dyer for the partnership with the MR stirrups and giving us the opportunity to further research them and test them.
Thank you, Alex. That was great. And thank you also to Dr. Dyer and Dr. Kaza. That was an excellent presentation. Okay, first question coming in. Do you think that live MR guidance is the only real-time viable alternative to live ultrasound guidance?
I don't think that it is the only alternative, but it is certainly the most promising one. There are brachytherapy radiation oncologists who will use fluoroscopy, which is very limited in terms of what you can actually see. clearly much more limited than MRI. I know that some radiation oncologists will do their implants in the main OR together with a gynecologic oncology surgeon who is doing laparoscopy, and that can guide the radiation oncologist with respect to needle placement through laparoscopic visualization. You know, obviously that doesn't help with tandem placement in an intact uterus, but can help with needle placement. And then, you know, as Alex mentioned, what we currently are doing is implants in our main HDR suite, where we have ultrasound and a CT scanner. So it's not live, but we will place needles, step out of the room, scan the patient with the CT, and then adjust the applicator based on those CT images, and then can take another CT image. But again, that's not real-time guidance. So I think MRI, has significant advantages over or any of those alternative options.
Okay, thank you. Next question, Alex, you'd mentioned some advantages of the MR stirrups to help the department better improve workflow. Are there any ways you can quantify accuracy, time, or safety, I guess, for the future outlook?
Sure. I think especially for our group, having the ability, as Dr. Dyer said, to make adjustments or even place the implant in the MR really saves lots of time in terms of the planning process, because the typical planning process, as mentioned, is there's an OR visit, there's a scan in the CT, and then there's a scan in the MRI. If we're able to either decrease the time the CT scan is, and the adjustments aren't done during the CT, but the adjustments are actually done in the MR itself, we're able to really cut the time of the planning process. Because currently, at least for our group, we're doing all of the planning on the MRI, and the MRI a lot of times for a lot of centers is the final step, and you can't start the planning until the MRI is done. So if we're able to do the adjustments in the implant in the MR and acquire the MR initially, even if you do have to get a CT scan, you could start the planning process as that MR, once that MR is acquired. So we haven't really quantified it, but you're probably saving anywhere from an hour to 2 hours.
Okay, thank you. Next question, Alex, also for you regarding training. You mentioned there are some differences that require additional training ahead of time. How quick is the learning curve, and were there extra requirements for those without MR training?
I think for us particularly, we had always used the Dyer sled or the hoverboard, but we had different variations of the stirrups. So some of the stirrups that we have aren't Dyer stirrups. So I couldn't speak to the comparison from Dyer non-conditional to Dyer MR conditional, but the stirrups that we compared to were non-Dyer products. So the stirrups themselves the functionality is slightly different in terms of how they clamp onto the board, where the screw position is to clamp the board, how they're attached. The boot itself is a little bit different. I would say not functionality different, but just in terms of how it Velcros, and then changing the shock itself to move is slightly different. I would say it's not something that is a long learning curve in terms of using the system, but definitely something that needs to be tested, I would say, on a volunteer or just with the system itself before it's used on a patient, just so people are comfortable with it.
Okay, thank you. Next question for the group. In your current workflow after the MR and any needle adjustment, do you then move the patient back to the CT suite to get a scan for needle identification and dose calculation, and then the MR is fused for target delineation? That's the question.
Yep. So the currently we have a few workflows, and it's logistically in terms of OR availability, but our OR also has a CT scanner on it. So we have two different workflows we can go by. We can either start the implant in the OR and then do a CT scan. The CT scan will then help with some of the adjustments. Take the stirrups off, glue and place the implant in place, and then do a final CT scan, and then we can transfer the patient to our MRI and do a MRI in that position, and then the planning can commence. The other workflow we have is there's another suite in the hospital as well that we use that has an OR, a MRI, and a CT scanner in it. In that area, we can do the implant in the OR, and then we can move over to the MRI, in which we still have the patient in stirrups in the MRI, and it allows for adjustments. So we actually, instead of adjusting off of the CT scanner, we can adjust off of the CT image, I should say. We can adjust off of the MR image, not live, but we can acquire a T2 image and then adjust some of the needles, do all of the final placements and measuring in the MRI, and then scan as a final step in the CT. What these stirrups allow us to do is, in our rad-onc department, our MRI suite is also equipped as a procedural suite, or an OR suite, if you will. And if the patient is already on the stirrups themselves, we could do the implant in the MR, in our MRI room initially, scan the patient with the stirrups, make some adjustments there, do a final MRI image. The planning can start then, and then while the planning is starting, since we're not fully MR only yet, we can do our CT scan as well. So there's a couple different workflows, and it all depends on where the initial implant is done. But this MR conditional stirrup system gives us the flexibility to kind of implant a patient into any of these workflows.
Okay, thank you. Next question coming in. You covered this in some detail, but just to kind of recap, how did you confirm no collision issues after the implant and before the scan?
Our CT scanner is 80 centimeters. The bore is 80 centimeters. In the MRI, we have the largest bore, which is 70 centimeters. The Dyer system itself fits the sled itself fits well into both scanners. So unless the patient is a large patient that hasn't fit in MRs in the past, which we would get alerted to prior, we haven't seen any issues with collisions. In terms of the stirrups themselves in the MRI, you do have less range of motion for scanning, given that it's a smaller bore. So the typical lithotomy, or maybe not even lithotomy, but the position you may be used to scanning a patient in a CT scanner in with stirrups, it's obviously going to be a tighter position. But having the implant in and moving the stirrups to that smaller position can still get you into a place where you can fit through the MRI scanner.
Okay, thank you. Next question is around just sort of the flow of the accessories and identification. Do you use any kind of stickers or any other identification to denote the MR conditional stirrups?
Since we have our stirrups marked with MR conditional stickers, additional MR conditional stickers. There are some markings on the boots itself, but we added extra stickers to the stirrups. The hoverboard as well, we added some extra stickers, but I believe they do come from the manufacturer with stickers as well. I'd have to double check.
Okay, thank you. Couple more questions. Are there other challenges of a CT-based program versus an MR-based program that you did not anticipate?
Well, Mike, if you can think of any, but I think the logistics, definitely the logistics and trying to implant, not even implant, trying to have all these stops into a workflow that that works in terms of patient timing. Because given, at least for us, we want to start planning after the MRI is completed. And given that the planning can only start once the MR is completed, there are a lot of stops for the patient. Also, I would say anesthesia. There was a lot of talks initially when we were building this suite in terms of workflow and what anesthesia needs. I think that was a big thing that we know was needed, but maybe we didn't take into account, the different needs from anesthesia, modeling the workflow itself throughout the department. And we did a lot of dry runs with anesthesia with okay, now we're disconnecting the patient from the OR. What does it look like walking through our hallway with the patient being bagged versus off of a ventilator? And how does that work for MR safety? And it evolved into a lot of checklists for us. So what we do is we have a checklist that starts with the patient initially in the OR and continues throughout till the end of the procedure. And it helps just guide MRI safety, different roles for different role groups, and things like that. So I think heavily weighted with anesthesia and all the other, definitely all the other disease site groups.
Yes, I agree with Alex that the main challenges are logistical and related to workflow and also just overall procedure time. We are not currently at a place where we're doing MRI only based treatment planning, which is where we would like to get to. So having to do both an MRI and a CT is more time consuming, not just for the time it takes for each of those scans, but the transportation between the two, the image registration and fusion between the two scans. All of that is time consuming.
Okay, thank you. Final question. Do you have any difficulty with getting the patient sled close enough to the end of the MR table such that you have good access to place or adjust the needles?
When we are adjusting the needles, the patient actually gets brought out of the MRI. I guess let me go back a step. There's two different things we had talked about. We had talked about one being real-time MR guidance. And yes, during the real-time MR guidance, the patient has to be at the isocenter while they're being scanned. And that can bring about many issues in terms of clearance. So our kind of model that we're researching off of is the patient's being scanned inside the MRI, and then there's a live feed going into the room via a monitor, almost like a TV monitor, where the doctor can see say a sagittal image, sagittal MR image, and then they actually can see the needle and where it's going in the uterus. Say, yes, there are a lot of issues there in terms of the patient's at the isocenter. How is the physician in the bore enough to place the needle, to move the needle? That is definitely a logistical issue in terms of where are the stirrups, where is the sled. In the workflows that we have used and where we're making adjustments, we're actually doing a static MRI image. So we would do, say, a T2 weighted image. We'd image the patient, and then we'd bring the patient all the way out of the MRI. So we're actually not doing the adjustments inside of the MR bore, so to speak. We'd actually move the patient out of the MRI, move the stirrups to a position where we can access the implant, make the adjustment, move the stirrups back down to where they fit into the MRI, and then re-image the patient. So in that case, we haven't seen any issues because you're bringing the patient all the way out. But in terms of the real-time MR guidance, there's definitely space issues that need to be thought of.
Okay, thank you so much. We are up on our time for today. There was also another question around availability of the sled and the stirrups outside the US, and just to confirm that they are available outside of the US currently. Again, thank you so much on behalf of DICOR. We'd like to thank the clinical team from the Dana Farber Cancer Institute and Brigham and Women's Hospital for this great clinical presentation today. And thank you for your attention. And with that, I'll conclude today's session. Thank you so much.